I think in that case, we can move on to the next rapid fire. It is somewhat along the same veins. The title of the talk is The Impact of Comorbid Depression on Mortality and Amputation Risk in Patients with Chronic Limb-Threatening Ischemia. It'll be given by Dr. Tara Zielke from the Loyola University Chicago Health Sciences and the Stritch School of Medicine.
Hello, my name is Tara Zielke. I am a second-year medical student at Loyola University of Chicago Stritch School of Medicine. I'd like to thank all of my co-authors, and today I'll be presenting to you the impact of comorbid depression on mortality and amputation risk in patients with chronic limb-threatening ischemia. We have no disclosures. And just a little introduction, peripheral artery disease, or PAD, is actually increasing in prevalence and affects over 8 million people in the United States. There are several well-established risk factors that I've listed here, and a subset of PAD patients actually go on to develop chronic limb-threatening ischemia, and this occurs in about 11% of PAD patients. A recent analysis of untreated chronic limb-threatening ischemia showed very high amputation rate and mortality of 22%. So a little introduction as well about the current literature. A study by McDermott et al. Found that depression was present in 22% of patients with PAD, and a study by Dr. Shipper-Arya and her colleagues found that comorbid depression in a VA PAD population was associated with higher amputation and mortality. So I became very interested in investigating depression as a potential risk factor for chronic limb-threatening ischemia, amputation, and mortality. So our objectives are to determine the prevalence of comorbid depression in this population, and then assess whether or not comorbid depression has an impact on amputation and mortality. And lastly, we'd be very interested to see if antidepressant treatment is associated with improvement in these outcomes. So this is a retrospective single institution chart review, patients 65 years and older with chronic limb-threatening ischemia, and we decided to define comorbid depression as an ICD-9 or 10 code 6 months pre or post PAD diagnosis date. We then use multivariable logistic regression models to estimate the effects of comorbid depression as well as antidepressant treatment on our outcomes of interest of major amputation and all-cause mortality. So we had 2,987 patients in our study. Mean age was 68.6 years old, 56% were male, and 68% were white, 24% were Black, and 12% reported as Hispanic. So looking at our results, overall in our entire patient cohort, the amputation rate was 14.8%, and the mortality rate was 23.6%. The mean follow-up at current follow-up is 2.4 years with a range of 13.2 years. So these results here, comorbid depression was present in 7.1% of patients, and these figures below demonstrate the differences in amputation and mortality just visually in this population. So you can see on the left, these are patients with comorbid depression, and the right, patients without comorbid depression. So looking at major amputation, comorbid depression was associated with an increased risk of amputation. Furthermore, another significant result was that antidepressant treatment is associated with significantly reduced mortality in these patients. So several conclusions. The first is that comorbid depression is associated with a worse prognosis for amputation and mortality, and that medical treatment of comorbid depression is associated with decreased mortality. So I'd like you to leave with this take-home point for my presentation. It's really the emphasis that patients with CLTI should be screened for depression and medical treatment should be considered. Thank you. I'd like to again thank my co-authors and Dr. Bernadette Aulivoloa for her mentorship. Thank you.
Thank you for that wonderful talk. I think depression and mental health is such an important factor in vascular patients that we kind of see it as an addition rather than another significant disease process. I just had actually a few questions. Now that you know this, have you guys implemented any changes in mental health assessment or intervention in the CLTI group, knowing that majority of them will eventually may need an amputation?
So at our specific institution, we haven't, but I think that is a great avenue for the future because I think it should be standard practice at a visit for a vascular surgery patient for them to be screened for depression because the incidence in this population is so high. And I think this study really does show that if you can appropriately treat these patients, that you can ultimately impact their clinical outcomes as well.
Mm-hmm. Did you, in your study, notice any differences in perhaps Is there a difference in the timing or in the rates depending on how much the depression impacted their activity?
So we did not look at their activity level, but I think that, similar to what this prior study was discussed, which I really enjoyed, I think it is really important to look at several different factors, right? And I think depression, one of them is mobility that this prior study highlighted. And I think that in the future, I think if we do more studies looking at mental health, mobility should be included because I think it is a factor definitely in terms of these patients and their quality of life.
And just as a follow-up questions, in the group that ended up getting amputated, was there a change in their actual degree of depression or their need for mental health, interventions? Meaning, in the end, once you took a disabled leg in their mind, right? Maybe it was the chicken and the egg discussion that we had earlier, and you actually did the amputation, maybe they qualify for prosthetic. Was there a small group that actually improved in their depression?
So we did not look at depression over time. We more just looked at whether or not they fit our definition of comorbid depression and then ultimately, but I think a future study, I think that would be really interesting to look at post amputation if that impacts the degree of depression in these patients.
Well, very good. Thank you for this important work, and we look forward to seeing the follow-up studies that you have planned for us.
Thank you so much.
You're welcome. I'm going to turn it back to Dr. Hicks.